So I want to thank NAPCRG and SAPC for the opportunity to come to this conference for the first time and present this work. And I first have to acknowledge also the work of my co-investigators on this slide on the very long haul of a cohort study, and also to the Health Research Council who funded it. So this is where we carried out this cohort study in the province of Canterbury. Canterbury is very parochial as a province. It has the best rugby football team in New Zealand, and this is important. I want you to remember this for later on. It grows many sheep as well in a ratio of 4 sheep to 1 adult, and that's also important to the context of the talk. And the city of Christchurch looks very much like the cities that you all come from in many ways, and the population looks the same as well. And this is where I was practicing in both clinical practice and as a researcher. So one of the great joys of clinical practice is that in almost every clinic, with almost every patient, research questions fly in the door. And this is one of the questions that appeared for me probably when I was just beginning clinical practice, and I'd read an article about iron deficiency anemia affecting behaviour in young children, and wondered whether what I was seeing in front of me was not just a case of being 2, but maybe I was seeing cases of iron deficiency anemia. But what I found in patients when I looked, and what you'll be seeing in your own practices, was not anemic children, but a whole lot of children with low ferritin, but without anemia. And there's uncertainty about what this means for brain development. And if it does mean something and it's this common, there's uncertainty about whether we should be more active in looking for it. So the clinical concerns around iron deficiency anemia are centred on these 3 domains: IQ or intellectual ability, motor functioning, and behaviour. And it's not clear what the mediating factors are between iron deficiency anemia and these poorer neurodevelopmental outcomes. Is it the iron deficiency itself? Is it the low hemoglobin that comes with the anemia? Is it confounded by the association between high lead and iron deficiency? Or is it just the socioeconomic disadvantage that exists that coexists with children with iron deficiency and high lead? Or is it some unknown confounder? What we do know is that iron deficiency anemia prevalence is relatively uncommon in the countries that we live in. In the US, for example, it's around 2%, similar to most countries in the Commonwealth. But low ferritin without anemia, we see much more commonly in clinical practice, anywhere between 14 and 29% in most developed countries. It's about 1 in 5 children in New Zealand, and probably similar in the UK. So the question is, does this much more common condition have the same associations with poorer brain or neurodevelopmental outcomes as iron deficiency with anemia? There are problems with the existing data. There have been some studies done in this area. Most of them have got inadequate sample sizes. They've got inadequate measures of the kind of confounding variables that I just talked about, or the measures of iron status were inadequate, often just using hemoglobin rather than a wider range of indices. Frequently, the follow-up time is too short. Really, age 6 is about the first age that you can measure neurodevelopment in a way that predicts longer-term outcomes. And there were sample selection biases. So what our study aimed to do was to look at whether there was a dose-response relationship or a threshold relationship between iron measures or iron status at 15 months and cognitive ability, behaviour and psychomotor function later on at 6 years. We chose this alternate and sort of novel way of looking at iron deficiency because iron deficiency anemia, or iron deficiency, whether you have it or not, depends on what threshold you set for a cutoff. So it's a bit like diabetes in that ferritin is a continuum, and it's kind of arbitrary at which point you set the cutoff, whether you decide people have the disease or not. So we chose to look at it as a continuous variable instead, to try and identify whether there was an important pathological threshold, if you like. To do this, we created a longitudinal birth cohort. We randomly selected midwives from a full range of maternity care facilities. And of the 505 parents, 448 agreed to participate in the iron study. We chose the demographics of our sample were pretty similar to the national demographics, except we had more first-born children than in the national data set. And at this level, it was powered to detect associations in the small to moderate range, and I won't read through the data there. We chose the exposure window as 15 months because it's within the window we know where iron measures are lowest in children, which is between age 1 and 2. And it also represented a point where if you were going to screen pragmatically, it's a time where immunisation is happening. So it represented also an opportunity for intervention if we were going to design those kind of studies based on the results. So we drew blood from children at 15 months, and we had to measure lead and hemoglobin immediately because it's light sensitive, but for all the other measures we stored them and assessed later the measures of iron status. If we'd let people know what the iron status was then, there was every possibility that they would have modified things and we wouldn't have been able to see what any effect was later on at 6 years. And we repeated all the measurements, the blood measurements at age 6 years. This is the range of iron indices that we measured. And we measured blood lead because of the association with iron deficiency in other populations. We also measured, and serum transferrin receptor levels were quite a new measure at the time, which we put in at the last minute, but they're quite a good measure of, so if ferritin measures storage iron, serum transferrin receptors measure the amount of iron that's available to cells at that time, real time, and so that measures better what the functional deficiency is. And those two indices are put together now in the mathematical construct of body iron as a continuous indicator of whether the child, or what level of iron the child has in their body, both in storage and functioning. Now this is a picture of one of my sons when he was 15 months old. And my biggest fear with this study was to get this birth cohort to 15 months old, and they would all refuse to have the blood test done. You can see that 15-month-old baby is quite chubby, and it's not a small task to get blood from a child of this age. But our cohort had nerves of steel, and we had almost no refusal of the blood test at 15 months. The outcomes that we measured covered standard measures of IQ, of motor functioning, and of behaviour. And that wasn't the big job, really. The big job for this cohort was measuring all the covariate data that could also affect these outcomes. We collected all this data from parents after birth, at 15 months, and then again at 6 years. The main IQ measure was the WISC, which a lot of you will be familiar with. It's very commonly used in children of this age, and we had population norms for the New Zealand population. It's got some standard subparts, 4, and we also added the arithmetic subscale because that was found to be associated with poorer outcomes in measures of iron deficiency, anemia, and later developmental outcomes. For motor function, we used the Brunick-Sosretsky test, and it took us all 5 years to learn how to pronounce that, of motor proficiency. And it's quite a good test. It's not too long, but it does assess both fine and gross motor proficiency, and it measures the things that have been associated with poorer function in iron deficiency with anemia. And for behaviour, we used the Connors, again, a well-known rating scale or measure of behaviour that allows both teachers and parents to assess behaviour, so in 2 different contexts or settings. The confounders that we wanted to measure, we chose from the literature. There's a large birth cohort study literature that looks at predictors of IQ or neurodevelopment. And so we chose to measure all of the confounders that have been used in the modelling associated between lead and cognitive outcomes, all the confounders that have been found to be associated in the literature in the association between iron deficiency, anemia, and cognitive outcomes, and any potential confounders that have been identified in critiques of these literature. We also measured this very wide range of socioeconomic and family variables, and I'm not going to read them all out, but you can see there that we went to a lot of trouble, and that this was the bulk of the work of the study, was really to try and measure accurately all the things that could be interfering in any association that we might see. Even things like planning of pregnancy affect later intellectual function. So these are the results. We had really great cohort retention 6 years. We didn't lose any children to follow-up at all. We didn't have data on outcomes in 4% because they were geographically inaccessible and 2 children had died. We tried to, and this is a family in the north of England that I went to see and assess when I was over here for a conference. So we tried our best to follow up people who were in different geographic locations, either when they come to visit or if some of the team were going over. We had 5% missing data on our 6-year blood test because a meningitis outbreak occurred during the study and there was a mass vaccination or immunisation campaign, and that made some children a bit leery of having another needle, so that's kind of unfortunate timing. But we had no other missing data in the cohort. And that's largely due to this woman, Anne Dalwinen, who was our major tester and tracker, and her persistence and attention to detail were really the core of the results of the study and its success. It was due to her efforts that we lost no children to follow up and that we have complete data. And you can see here, just looking at her, she's the kind of person that children would love to come and see, and they did. They loved to come and see her for their testing and kept in communication with her even years after the study finished. So what did we find? Well, we found what you'd expect among the blood measures, that blood iron was correlated at between 15 months and 6 years. We found no relationship, interestingly, between iron and lead at 15 months. However, there was a small significant association at 6 years, which you might expect because lead tends to accumulate in the body over time. But you can see the slope's fairly small there. Lead levels, we found a number of high lead levels. 11 were above the notifiable level at the time, and a further 18 were reasonably elevated. So this was kind of interesting and important information. We also found the psychomotor skills levels were skewed to the right, that the New Zealand group had better motor skills than the USA normative group, which relates to my comment about the rugby team, and maybe that's why the All Blacks do so well. Just to give you an idea really of the iron measures, and the key piece of this table is the proportion who have ferritin and what we'd consider to be below a normal range. So about a quarter of the sample or that group of people who present to us with low ferritin but no anaemia. We saw very little anaemia as we expected. So the main results. We found no relationship. So I'm presenting to you the opposite conclusion to what I expected. I expected that we were going to find a dose-response relationship, that it would be important, and I'd be advocating that we should be screening for it with immunisation. But we didn't find that. And you can see here just some examples of the kind of analysis. We didn't see anything on the working memory in the WISC. We didn't see anything on the fine motor skills subscale, which is where we expected to see any effect, if there was one there. We didn't see any effect on behaviour. And here again, I don't expect you to read this, but this is just to show you that the effect sizes were small and the confidence intervals were very tight. So we're pretty certain that there is no effect, or that if it is, it's probably at a level that's not clinically significant. And this is just to give you a visual idea of what that association or lack of association looks at, because it's easier to look at pictures than it is to read tables. So you can see here that this is the association between total body iron and IQ. That's that mathematical construct. To put it into our clinical context, if we measure ferritin, we don't calculate total body iron. And again, you can see a completely flat line. There's no evidence of any kind of dose response or threshold relationship. Here again, you can see the same complete absence of association for any of the domains of the IQ test or for overall psychomotor function. There's a completely flat line. Here are fine and gross motor skills. Again, you can't see any sign of any association. And this is the parent behaviour rating, and the teacher rating scale looked exactly the same. So we can conclude, I think with reasonable confidence, that early iron status isn't associated with poorer outcomes in terms of intellectual performance, motor performance or behaviour at age 6. We didn't find any shape of association at all. We did find that these low iron measures are common, and I think that these data from a developed population with extensive covariate data are quite reassuring. Much of the work on iron deficiency anemia and negative outcomes was done in developing countries, where it may well be a marker for other things that are going on in the social environment. And I think that they provide reassuring information for clinicians and for parents, because there's a great deal of concern about iron deficiency and will it affect my child's brain development. Certainly in New Zealand, the Lamb and Beef Marketing Board run advertising based on that fear. So I hope it will help avoid substantial overdiagnosis, overtreatment and anxiety, and maybe prompt us to perhaps look at the normal ranges for that age. It may be that what we're looking at is that this is a physiological dip, and that we're looking at a normal range problem rather than a real problem. What we did find was that there are other important influences on development that we can modify. So again, just to show you the 3 covariates that were significant predictors of later intellectual function were maximum years of parental education, as you'd expect. I don't know if this has got a pointer. No, it hasn't. But if you look at the top lines, you can see that that is mostly associated with IQ. But home score and planning of the pregnancy are associated with pretty much all domains of intellectual function, of behaviour and of motor function. And that's something that we in primary care can have an influence on planning of pregnancy. And home score measures how stimulating the home environment is. And it's not necessarily associated with affluence. It's associated with engagement and activity. So these are 2 domains that maybe we should be focusing on if we're trying to give our children the best start that we possibly can. Lead was also a significant predictor of worse outcomes, which we expected because it's known, but we were reassured that we were able to detect this effect. It's a fairly subtle effect, but we were able to detect it in our cohort. And again, we found it over most of the domains. And the interesting thing is, at the moment there's a threshold for abnormal lead and notifiable levels, but we didn't find any threshold. It seems that lead is bad for your brain, even at low levels. So that has implications for, again, how we manage it, and that maybe we shouldn't look at thresholds, we should just look at overall mitigation. So the implications for us in primary care, the data doesn't support any need to either screen or treat or worry, that there are other potential modifiable influences on our children's neurodevelopment that we can influence. And the last thing I want to say is thank you to Anne, who was such an important part of completing this study, but also to the children and parents who gave so willingly of their time over the 6 years, who we got to know well and who brought great joy to our department when they visited, and who we miss very much now. So thank you for your time.